Welcome to the board meeting this afternoon. We've got apologies from Simon McMillan, Deborah Shepherd, Harry Turner, Lynn Corley, Peter Featherstone, Felicity Mercer, and Lynn Corley. I'd also like to welcome Cheryl Etches to our first board meeting, or your first board meeting, sorry. Welcome aboard. Look forward to your contributions in due course. Also to Councillor Heather Kidd, welcome to the ICB, and we look forward to working with you in the coming years. And finally, this is Patricia Davis's last meeting with the ICB. So thank you, Patricia, for all your hard work and contribution over the years. Much appreciated. Thank you. Just another point, there's a sad announcement which Simon will discuss.
Yeah, so look, many of you will already be aware, but it's absolutely appropriate that we acknowledge the very sudden and sad passing of our colleague for Robert Jones and Agnes Hunt, Sam Young. For those of you that don't know Sam, she was serving as the interim chief nursing officer at Robert Jones and Agnes Hunt, and was a truly deeply respected and valued member of the team there, but also the wider NHS and community across Shropshire, Telford and Wrekin. Her career reflected an absolute lifelong commitment to serving others, whether that be in primary care, secondary care, community-based care, armed forces. She was a military reservist. I was just hearing she was also in the process. She's got an amazing singing voice, and we're also going around with a number of retired GPs doing gigs across Shrewsbury as well. For those that worked with Sam, will remember her for her clinical skill and focus and attention to detail, but balanced with that warm compassion and absolute unwavering dedication to patient care and getting the very best for every individual that she works with on behalf of. Her loss has been and continues to be felt across the system, but particularly with colleagues at Robert Jones and Agnes Hunt. So on behalf of the board, I extend our absolute heartfelt condolences to Sam's family, friends and colleagues, to Stacey and Harry, Robert Jones. Pass on our condolences to you and to the team and to anyone else that had the privilege of working alongside. Thank you, Chair.
Thank
you.
Okay, we now move on to the next item, which is any declarations of interest. Does anyone have any declarations of interest on any item on the agenda? Minutes of the previous meeting held on the 30th of April and the 20th of June. Any comments? So, we're happy to approve those minutes. Thank you. Actions arising. I think they're all pretty much in progress. There were just two of them which I felt both covered UEC and winter pressures, and whether it's just worth combining those two together. They're the two last of the results. Those two together.
Yeah, so the board will remember a couple of months ago we presented current plan this year for improvements in UEC and also the initial planning for winter. We're also guided by our regulated NHSE around expectations of having a winter plan ready for us as a board to approve in late July, early August. But we'd also like to propose that we would come back in September to give a much fuller presentation around impacts so far this year on the improvement plan, but also our preparations and our mitigations that are going into this coming winter. So just to assure the board, we are in full mode of both in terms of delivery of improvement this year, but also winter preparation, because it will soon be here on this warm summer's day.
So on that point, we just add some dates and sort of coordination between two working away. Good, thank you. questions from members of the public. We've had 16 questions from members of the public, so thanks for those questions, and we will answer them in our standard way in writing in due process as quickly as we can. Thank you. The next item is the resident experience. This is a talk on frailty. And Lorraine.
Thank you. Angela has kindly joined us. So the other thing to say, but clearly anything that's stated for the human frailty is a critical pathway in terms of transformation. And Angela's here to share an education story in terms of the work that we're doing and continuing to do. So thank you.
Angela, when you're ready. You hear us, Angela?
I can. Apologies, I'm having a few Teams issues at the moment. It's just a little bit slow. I'm just going to share a presentation with you. Can you hear me okay?
Yes, we can.
Oh, wrong one. Oh, I'm not having much luck with this at the moment. So I'm going to talk you through 3 different patient stories that highlight the 3 different areas where we have been making some improvements within frail. I'm just going to drag the screen across because you don't want to see me. So it's 3 different patients. They are 3 real stories of experiences of our patients that have come through frailty, either in Telford or in Shrewsbury. And I just want to highlight some of their experience. So patient number 1 was an 85-year-old lady who came in, who lived in a care home. She was known to have a dementia, anxiety and an agoraphobia. She was on multiple medications in order to manage these conditions, but she didn't do very well outside of her familiar environment, which caused difficulties when coming into hospital. English was not her first language, but she was fluent when she was quite well. So from a frailty perspective, she was sent to ED following an episode of low blood pressure in her care home. She had been poorly throughout the week. She'd had a viral illness, and this had caused some episodes of vomiting, which made her weak and not her normal self, so that sent into A&E. She was then isolated in a side room because of the vomiting, just to protect herself and other patients around her, and she'd been in A&E for 24 hours. She was very upset at this point because she doesn't like it being in unfamiliar spaces. She doesn't like it when people are not around her. So her anxiety levels were really quite high at this point. She was a very high risk of falls, so she was nursed in the bed. She had IV fluids in progress to support with the vomiting. And she was communicating was challenging because she was quite distressed because of the noise of the A&E department, which naturally is normally a quite busy environment. So every morning our frailty team come in, they will screen all the patients in A&E and they will seek out anyone that would fit that criteria for frailty, and they will then intervene. So the team screened her, they changed her into her own clothes, they walked her to the toilet, and that's just assessing her mobility and getting her into her day clothes to make it just so she knows the time of day really. We then took her up to FAU, sat her in a chair space rather than getting her back into bed. We put a radio on. It was a lot calmer environment for her, because we are only 4 beds and 4 chairs, so it's a much smaller environment than the A&E, which means it's a little bit more settled. So the FAU staff are based within the assessment unit, therefore they were visible, and this really helped with the anxiety of our patient. And they were responded to her needs as they came up, and they supported her with taking the medication. So on the back of this, the results of this were she was able to sit and stand with her frame within an hour of coming to FAU, and she was walking back and forth to the toilet as needed with assistance. After she'd had her medication, she was eating and drinking, she was not vomiting, and she was holding down her food, and that meant that we were able to return her back to her care home on the same day, and we referred her to the virtual ward to monitor her low blood pressure in the community. So just a real success story on taking someone out of that busy environment that's not familiar with it, and how we can get them back into their own environment as quickly as we can. So what we did from that is we kind of estimated what could have happened had she not been taken out of that A&E environment. So she possibly may have remained in bed and deconditioned, or missed doses of a medication that was supporting those cognitive conditions of hers. The behaviour may have escalated due to the anxiety and the dementia, which would have led to a prolonged admission. She would have had a reduced ability to engage with the MDT to participate in assessments. Her reduced oral intake meant she would have been probably medicalised for onward IV hydration. So I think a real success story for our patient. The second story for our second patient was an 89-year-old female, and she came in from her own home. She was cognitively intact, she was mobile, she was independent, but for a week she'd been struggling to walk, so she presented herself to A&E. When she got there, they confirmed that she had a fracture, and they provided her with a boot and a fracture clinic appointment, and then what she wanted to go home, so that she was discharged at her own request. The following morning, she turned up at the fracture clinic and stated that she'd been really struggling at home. So she was advised not to wait there, and she was placed in a plaster of Paris, referred to the frailty assessment team, and then she was taken direct to FAU and avoided A&E altogether. And this is the first patient we actually did this with, and it worked really well. So she was seen by the multidisciplinary team within 2 hours. So she'd had an ACP consultant and therapist all input into her care within the first 2 hours of admission. She'd had a full comprehensive geriatric assessment. They planned for her to go to a pathway to community bed as soon as one was available, and that referral was done straight away, and it was done on an admission avoidance pathway rather than going on to an inpatient pathway. And the care that was then discussed with the next of kin, they were updated frequently throughout the day, and the staff were again visible just to make sure that her needs were met. And we have had some lovely feedback from the patients, just to say how well they were cared for within the FAU. So, apologies. So again, what we looked at is what may have happened had the FAU not been available, and we suspected that our patient would have been moved into the from fracture clinic to A&E, and would have had to have waited for clerking. Maybe a prolonged stay because of the bed pressures that we've been facing. This was during winter as well, so we did have increased bed pressures at the time. There was a possible delay in referral just because of those pressures, put into any medical bed for and would have lost that admission avoidance pathway because it's not available in all areas of the hospital. So a really successful outcome for our second patient as well. And the final one I wanted to just take you through is a lady who was admitted onto one of our frailty wards as an inpatient. And this is a lady who was known to have dementia and became increasingly confused in an unfamiliar environment. We had to have a one-on-one special care for her due to this increased confusion and the purposeful walking up and down the ward. She was at high risk of falls, so we just made sure there was someone monitoring her closely, and she didn't quite understand where she was, why she was there. So as a result of this, we've got lots of new schemes that are going on within frailty. So we have a donate to motivate wardrobe, and this is where people donate clothes so we can get our patients dressed and out of bed in the mornings. So we were able to take our patient down there where she chose her clothes. We then took her to a cafe, which is an innovation area that we have designed on the ward, as you can see by the pictures. Being from an open ward environment, we've changed it into a small little cafe where patients can go and sit and have a cup of coffee, or as a patient called it, a posh cup of coffee. And the only difference was it wasn't a china cup. The coffee was exactly the same. But she was able to read magazines and she was able to read books. She reported as having a lovely day out, really enjoyed it, and her confusion started to improve as she had some purpose in her day. So really, really good feedback from patient and family. So just as a result, I just wanted to share a little bit of data with you. So we are above the trust average for patients getting up and dressed every morning, with both wards sitting around about 60%, and you can see by the data charts on the side that they are improving on a month-by-month basis. We have what we call a Bay a Day activity that keeps our patients active. That goes into Ward 9 because we're not able to do the interactive area or the therapeutic area because there's not enough space. There's an introduction. We introduced the therapeutic area, which is our cafe, on Ward 28. We've bought some specialist rise and recline chairs for those patients that struggle to get up and out about, so just to make things easier for them. We've had 76% of our patients reported feeling better, with 45 saying that their energy levels have increased whilst they've been in hospital. Unvalidated data, we are still working through it, but early indications are showing that hospital-acquired infections have improved over the last year, specifically on these wards where we put all this extra interaction in. Our one-on-one care for patients has reduced over the last 8 months. I'm just waiting for the figure to see how much that's reduced by. And very proudly, 77% of our patients are going home with no additional care needs, no increase to what they already had or any if they didn't have any before. So, and just a bit of feedback from our patients who've reported that the therapeutic area took the mind off the negative and upsetting thoughts in their head, and that it was a really good distraction from the dark and grey bays, as they said. And that is the 3 patient journeys I wanted to take you on. Thank you very much. Does anyone have any questions?
You, Angela, that was very good, very interesting. Any question? Yes.
Thanks, Angela. It's a really innovative piece of work. I think shows how you can, integrate together. I just wondered how this integrates back into the community on discharge, and is there something there in looking at this, how it works into the neighbourhood working going forwards?
So we work very, very closely with Virtual Ward and our community colleagues, especially around frailty. And what we've also started to see is a reduced readmission rate within our frail cohort. And I believe that's because of the care that they are receiving from that Virtual Ward pathway. And our consultants, my clinical leaders in secondary care, and also the consultant in Virtual Ward, are working together on an interface where we can do some more interactive, seamless care back and forth between community and deliver care closer to the patient's home where possible, through rapid response. So there's a lot of work, a lot of interface work going on with secondary care and community.
Yeah, absolutely. I guess my thinking is sort of further on from that rapid response sort of virtual ward phase, actually the long-term thing, like in terms of is somebody assessing this person in terms of their OT stuff at home, whether they're getting the right benefits, that sort of thing. And that's, I guess that's the sort of piece that I was thinking about, whether anyone's looking into that element of it. If not, it's absolutely fine. I just think it's somewhere that we could look to work on.
I think it's something that probably we need to work on a bit better. We have a great therapy team that meet our patients at the front door. We absolutely do. We do a lot of therapy referral on discharge as well, but I'm not 100% clear on what therapy, the step-up therapy we have in the community at this point. But I will certainly take it back to our feedback sessions.
I'd be really, if you drop me an email, and if there's something we can do to link stuff up, because I think this would work with stuff when the next week, I can't say. But yeah, drop me an email, because I think there's a piece of work there that we can do. We can look to pilot in our PCM in terms of the longer term consequences for these people.
That would be amazing. Thank you.
Yeah.
Thank you. Thanks very much, Angela. Unfortunately, we couldn't see your slides, so I think it would be great if we could circulate those, because I've seen some, if not all, of these slides, and they really are worth a look. So it's a shame about that, but as long as we do get to see them in the end. I think this really highlights how well one part of the frailty pathway can be enacted. But it's the part that we want to make sure we stem the flow of people coming to as well, so that the frailty units, when the person who's frail arrives, they've got enough capacity to deal with these people through the frailty units. But actually, we're taking that, as you know, as Jess rightly said, much further downstream into our neighbourhood approach, our primary care approach. How are we keeping people in their usual place of residence for longer and avoiding that frailty crisis as much as possible? So a frailty strategy has been developed, which is currently out for consultation. We're closing it on Monday to the general public's comments. It's been around various community groups, but also an online survey that's attracted 475 respondents, which we're really thrilled to bits with. So, you know, thanks to everybody that's taken the time. And the professionals one closes a week later, and that's doing really well as well. And that culminates in a professionals listening event. So we've got lots of work going on to really join up all of these different parts of the frailty work and really try and address frailty with you know, our community approaches with the local authorities, therapies and community services right at the, you know, heart of where it's happening. Thank you, Angela.
Thank you.
Yes, also to echo what Jess is saying, I think the important thing is that in due course, the restructuring will be what happens, because it's how we reciprocate what's being done for frailty post-social. And the neighbour approach is fully home into that the ICB in terms of risk stratification, so we can really do individualised care in the community.
Good point. Thank you. Any further points on this item?
Just thank you to Angela, who will certainly provide. And I just, when we bring the winter plan back, which is probably in September, with the frailty, we'll probably be able to go through what that looks like. This was set up really quickly. So just thank you to my colleagues for doing that. But I think the problem that this will give us is now how we find bigger space on site. But it's great to see the impact that it's had just in the months that we've had it in place.
I think we all echo that point. Well done, Angela. Thank you very much for your presentation. And we look forward to more progress in the coming years. Thank you. Okay. Moving down on to the next item, which is the Chair's report. I'll take it as read. Just a couple of points to highlight. First of all, Robert Green, who's the new Chair, will start on 1st of July. He will start next week, and he's looking forward to joining the board and working with ICB colleagues. Second point is the government reset programme on the future of ICBs. We've had announced last day that the clustering arrangement of Shropshire, Telford and Wrekin with Staffordshire and Stoke-on-Trent ICBs will head. That's now the direction of travel that we will follow. I've been impressed by the cooperation and working arrangements between colleagues both here and with colleagues in Stoke-on-Trent ICB. That's very positive. And we look forward to achieving the required goals over the programme of that process. Thank you for that. And then finally, at the end of the report, just to say that in a number of areas in 24-25 in our annual report, we've actually shown some real step changes in our governance and performance as an ICB and as a system. And I think that is very much down to lots of hard work by individuals and professionalism. But I think it's important to recognise the hard work that goes on behind the scenes to achieve that. And we have to take I think all the credit for our work as an ICB and our committee structures, but also the professionals that have helped us in achieving that process in the finance function. Thank you. Any questions on my report? Thank you. Moving on to the Chief Executive Board.
Thank you, Chair. So again, we'll take it as read just to highlight a couple of areas from it. You've already touched on the annual reports and the annual accounts in terms of 24-25, and to confirm to the board that they've been submitted by the deadline set by NHS England. and will be published on the website now, again, in line with the NHS England guidance. And we'll also have an AGM as well, where we'll have an opportunity for further conversation and further discussion about them. So just to note, we've made the submission deadlines, recognising the improvements that you've articulated in your report there. Myself, Andrew, Morgan and Joe presented at the Midlands Regional Chief Exec and Chair's Leadership event. That was well received. It's great to be asked. But we presented on the progress we'd made in terms of the journey so far, in terms of delivering plans and putting that into action, whilst also recognising that continuous improvement in the journey we still had to go in that regard. So positive in that space. I touch on the arrangements that we've got for continuing with the MP briefings and how we're developing a face-to-face. So how we're building on the quarterly face-to-face with a monthly written update that we're also sharing wider with stakeholders as well. So that goes to council, cabinet members, it goes to health and wellbeing board members, as well as to the MPs. I won't touch in detail, but important that I highlighted in the Chief Exec reports, the Equality, Diversity, Inclusion campaign, because that's going to get picked up in Vanessa's report later in more detail. So there'll be a longer conversation there. But that launched that and has landed really well and really positively. So I will let Vanessa talk about that in more detail. And you've already touched on, and in the previous conversation, touched on the healthy ageing and the frailty survey and where that's up to in terms of that space. So I reckon I note that as well. And then the final bit on behalf of the Chief Exec community is just to reinforce what you said at the start, Chair, is to thank Patricia on behalf of the Chief Exec community for her commitment and support and for the difference that she's made, and to wish her the best of luck with her future challenge in Manchester. And given I'm a Liverpool supporter, so anything in Manchester is a challenge. Even more of a challenge. But no, seriously, all the best, Patricia, and thank you for the difference that you have made whilst working in Shropshire's Telford and Wrekin. Thank you, Chair. Take any questions or comments.
Questions, David, and then.
Yeah, thank you, Chair. Just referencing under 2.8 relating to what we heard earlier as well, the healthy ageing and frailty strategy, very much welcomed. It links to one of the key priorities at TWIP as well. From a place perspective, we promoted engagement through various channels in Telford and Wrekin, including the Healthy Telford, and we'll give it a final push before the survey closes. So really welcome this work. So thank you.
And I do, sorry, I do think that's I think we are demonstrating some of the learning of using different routes to get that engagement and to manage that through different ways, and not doing the NHS knows the way that will deliver the engagement. So working with partners in a different way gets a much better reach, which means the information that comes back really helps bring some colour to the work that we then need to do. So thank you for that, David.
Just quickly going back to when you reported, and I guess question to both of you around public health and where we're expecting to see public health land in the new structures, because I think as part of whatever we do, there's a lot of information, a lot of stuff that sits in public health, and we've got a good working relationship with our local authority, but everyone in public health that I meet today is really worried about what's going to happen. A lot of folks are already starting to look for other jobs.
Well, I mean, we wouldn't want anybody to be looking for other jobs in public health. We've got two great public health teams in both local authorities and work really well with them. I'm not aware that there's significant changes being proposed in terms of public health. It stays with the local authorities. Clearly, as the ICB moves into the strategic commissioning function piece, and we really get into population health management, that relationship and connection with public health is going to be even more important than it is now. And the work that we are doing to build that network and build those relationships and build that commitment, I think is a great building block for what that work will look like going forward. So I would just want to recognise that we work well, we want to build on that and have the relationships in place to enable that to happen.
So I'm hearing a lot of whispers, maybe they're just whispers, and maybe I'm not that well connected as I used to. if that public health may or may not land where it is today, especially the level at place level and otherwise, it may sit somewhere else. And a lot of public health consultants who are currently sitting strategically in a region don't know what's going to happen. So that's what I'm hearing. And the reason I ask this question, Simon, is not because I'm interested in the politics. I don't give politics anymore. Sorry, please don't recall that. It's really to understand. I know we've got a great working relation. We've got some great colleagues who do some amazing work. We just don't want to lose them.
We've been really clear with staff all the way through on this reset piece at NITI, and recognise that the value of the intelligence, that we'll deal with the facts as they come in front of us, and we'll stick to the core bit until we get something otherwise or something to the contrary. The ICB blueprint doesn't articulate any changes in terms of public health. There is yet to the regional NHSE blueprint model region is still to be published, so there will be changes in that, I'm certain. But the important bit for us is the strength of the two public health teams that we've got, the relationships that we've got with those in the local authorities, and the commitment to build on that as we move into that more strategic commissioning function. And I see that only being a good thing, and clearly we want to demonstrate that across the cluster footprint and the same.
I might be able to come in and help you on that. I think in terms of the public health stuff, it's actually there are pieces of work that are going on at PCN level with public health department, really and doing loads of really integrated things, which I appreciate probably might not give you the reassurances completely that you want, but I guess, like I've had a really long conversation with Naomi Roche, like at lunchtime, about how we're going to work in terms of neighbourhood addressing the ship priorities and how that's going to work together with our risk stratification stuff. I know that Charlotte's had a very similar conversation looking at the projects that they've got going on. So actually there is a lot of work, and it might be little projects and things that actually I think those are the building blocks, and I would just seek to reassure you that absolutely public health very much in there. Craig came and talked about the risk stratification using OPAC and whatever, and we sort of said, well, how is this working with the public health data that we've got? So there's definitely a knowledge sort of with our PCM partners, I'm sure you'd agree, that we're very conscious of the value of public health, and actually that's not reducing. If anything, it's increasing, I'd say.
Okay.
Yeah.
Andy?
Just building on that, I think the issue around it for me is the protection of the locality working within a broader footprint that we're talking about. So within the cluster, how do we make sure that we protect that good work and can further develop?
Okay. It's a positive message.
I'm glad to hear that. I mean, I've heard the frailty strategy, and having been a doctor 100 years ago, so you can't. If you don't case find people, you don't know where they are, right? You don't know who the brave ones are, and that's about case finding and how you find them. And it's the public health doctors that have been in the past doing the regression analysis, figuring out who's at risk and all of that. I'm just worried that none of our strategies will work if we don't get that, if we don't protect our public health value enough. And I'm just giving this out as a message because I think in strategic commissioning, it's often been overlooked. But I think it is one of the biggest parts of the analytics that we need for strategic commissioning.
I think there's a lot more analytics going on in general practice now. So every practice is required to have analytics about appointments, and these analytics extend way beyond just appointments alone, about also about the public health arena, about frailty, about health inequalities in there. So general practice are skilled up or more skilled up than ever before in looking at public health related things. So I think most PCNs are now working with ICB, trying to work with ICB about the risk stratification, which we can do together. Can't be done just on PCN alone. So I'm hoping that is going to be a really positive thing in terms of case finding, not just about frailty, but also about other health inequalities in the system. And that's going to be a key about how we turn the dial in terms of making changes in the global sense for our population globally.
Okay.
Thank you.
It's all well made. Thank you. Any further points on this item? Okay, we move on to the strategic board assurance framework.
Thank you, Chair. So presenting the latest version of the system board assurance framework and the system strategic risk register and the ICB risk register with risks over 15. We'll take the report as read. Just wanted to highlight that we've got a replacement risk 20 replacing risk 28 on the system operating risk register, and a new risk at risk 29, and then on the ICB operational risk register we've got 2 new risks, 29 and 30. I hope that demonstrates that we are keeping a close eye on the risks, we're managing them, we're looking at whether the mitigations are working and looking to further action to mitigate whether that's possible. So we're asking for noting of the report, review of all of the documents, and your any comments or anything that you want us to look at in more detail for next meeting, or take to committees for them to look in more detail, and to be assured that we have management of the risks that the ICB and the system is holding.
Thank you. Questions or points? I think just to say that during the course of the past year, we've made a lot of progress on risk assurance. And I think that's down to the hard work of everybody, particularly the committees, and taking ownership and reviewing their risks on a regular basis. Thank you. Right, health inequalities.
Thank you. If I just do a couple of brief comments and hand over to Tracy for the additional key highlights. I suppose, especially just perhaps with some of the comments that collectively we've been making, I think we know that addressing inequalities is a really important core objective and for the ICB and ICS, and we absolutely take this seriously. I think whilst we recognise that we've got a national framework, key lines of inquiry, and that's an NHS England national framework, and of course we report against this. The approach and the way in which we do this in STW is absolutely a multi-agency one, and we have, for example, a system prevention and health inequalities group, which is chaired by one of our directors of public health, Helen in David Sidaway's team, and so public health and the discussion we've just been having there around the data with analytics teams from the ICB and other colleagues across NHS and local authorities is utterly pivotal to that. I think the other one is just to reinforce, and again, Andy just mentioned it, the way in which, again, this is deployed. There are some specific areas of focus, but it's really reinforced through our 2 places and through neighbourhood and locality level. That's where we're going to really pull together the wider inequality and indices of deprivation alongside healthcare inequalities. So I just wanted to assure the board that that absolutely runs through the work that we're doing. And certainly, as we know, neighbourhoods are so important. It's an approach we briefed at the board last time, but that's really pivotal to what we're doing across the national health system.
Thank you, Nigel. I think Nigel made a very important point that I was going to start with, which is although the paper is presented to you, is an annual report of our progress against the National Healthcare Inequalities Programme, and therefore really focuses in on those core areas within that programme of work. It isn't to minimise the wide area of in the health and care inequalities and wider inequalities work that we know that's happening across the system. Jess, you mentioned earlier about PCN work, and I know certainly looking at place and neighbourhood, there's a whole schemes of work around healthcare inequalities that may not necessarily be reflected within the annual report as presented to the board, because we are focusing in on a report in relation to the NHS Improvement Healthcare Programme. So it's a very detailed report, and it also has accompanying it some very detailed appendices. So I thought it might be helpful for the board if I perhaps just very quickly summarise some of the key points within it. So it provides a summary of the achievements against the plan that was set last year, which looks at, firstly, in terms of the programmes of work were people able to achieve those milestones and deliverables that they set out at the beginning of the year? And you'll see that the majority of those were achieved. And for those of you who want to look into the detail, Appendix 1 actually provides you with an end of year report for each of those projects and programmes of work. The report also highlights some of the key challenges that those who are running the programmes and projects of work have fed back as part of the reporting templates and as part of the discussions that we've had with those individuals. And these key challenges relate firstly to work around data, both in terms of completeness and also in terms of the granularity of the data we need. Because when we're looking at healthcare inequalities, we're wanting to start splitting out the data by some of those indicators that we know have an impact upon people's experiences of healthcare. So that is things like people who are in the core 20, it is things relating to ethnicity and also to gender split. So we're starting to want to have that granularity of detail across all of our programmes, but at the moment that is limited. It also talks about some of the challenges that we have as a system and that we acknowledge within our risk around all of our competing priorities in relation to the pressures that we know collectively as a system we face in terms of financial pressures and performance pressures. And then we do have a changing landscape, and we cannot escape the fact that as we move into one organisation and prepare to move to another, there will be some impact. But I will speak, just as others have, as to when I work with the people who are leading these programmes of work, everyone has that focus on going forward, but there has been some areas where we've had gaps in capacity, and that's led to gaps in performance and achievement. Equally, the report really highlights some of our key achievements across the system. And so one of the things that I've picked out a few, there are several, I think there are about 5 pages of achievements within the report. The ones I've particularly chosen to highlight are the ones that involve all of us as an ICS. So when I look at the governance structure, especially within our provider organisations, we've seen a real strengthened governance structure around healthcare inequalities so that we have that accountability and also the support for those individuals who are leading the programmes of work. Particularly important we saw a joining up of partners across the system, and that's involving our local authority partners, our PCN digital and transformation leads, and our digital leads within the ICB and across providers to start looking at how do we join together the many pieces of work around digital inclusion into a whole system digital inclusion strategy. One of the other areas of work that we're starting to see progress on in Q4, and we thank Stacey for her sponsorship of this, is looking at how we're going to be addressing inclusive recovery. And we did have an additional piece of governmental guidance around the elective care reform, and we've seen work being done around this area of work now. We have system level task and finish groups, and one of those is directly addressing inequalities. Those of you who will remember the board report from last year, and I'm sure there may be 1 or 2, will remember this was an area where we hadn't seen any progress at all. So it's really a key achievement that in Q4 we have started making progress towards that. The other point that I want to raise is where we have seen progress, it's because people are following a quality improvement approach. They're using data to set out what it is they know about the current situation. They're articulating clearly what they want to change, and then they're able to demonstrate that change. And one of the key pieces of work that are cited within the report is the improvements we've seen at SAF in terms of children and young people from more deprived communities being commenced on their hybrid closed loops. The report then has a further section about impact, because we are able to demonstrate how the projects have moved against their expected planned deliverables, what they had within their programmes, what they wanted to achieve. There's another element that we need to all be looking at, which is the so what element. How have we seen a difference in quantifiable metrics and impact? That piece of work has evolved significantly over the last 12 months. And in the report, there are some examples of where we're starting to see some granularity of details. We can start to see some of the differences. What we do have within the BI team within the ICB is a inequalities dashboard that's been developed as part of our population health management approach. And that is now able to give us a different level of details. We can start to see the impact in not only just overall impact, but where that specific impact has happened. And that piece of work will be linking into the risk stratification and the work that we're doing at place. And then lastly, just really want to talk about the forthcoming year, because I think as we move forward with the government reset and we move forward towards our model ICB blueprint, one of the things that we will start seeing more and more of is the connection of health inequalities into place. Previously, a lot of the work has happened across the system, but certainly the commitment and the direction of travel will be taking the delivery mode for some of these very particular healthcare inequalities down into the level of place. And by place, I actually mean below TWIP and SHIP, and looking much more at those neighbourhoods and small place areas. Happy to take a question.
Thank you.
I haven't got a particular question, but we've had a chat, haven't we? And I think it's worth a statement across. I also chair, as voluntary sector rep, I chair the Hardship and Poverty Group for Shropshire, which works closely with public health and Rachel Robinson. And when we talk about those wider health equalities, but specific around the 5, and this isn't a political comment, I promise you, is that some of the changes around welfare reform and PIP are going to really hit the communities that are experiencing those health inequalities around cardiovascular, musculoskeletal, respiratory issues as well. And so I really look forward to that move towards prevention and linking in with the prevention strategy at place and lower as well. And as a voluntary sector lead, very happy to kind of feedback anything that you might want on that. I think prevention is the only way that we can reduce those inequalities.
Music to my ears, linking the two. So I'd love to hear more about, by the way, the hybrid closed loop and what happened. For your info, I'm now the president-elect of the International Diabetes Federation. I do this for a living, so I'd love to hear that story, more of that story. You know, I can publicize it more on a national and global level if you want to hear more. I'd love to hear more about that. But just coming back to case finding, your risk stratification and prevention, I guess I'd like to see some of the evidence-based tools that we're using around some of this, because it's fraught with difficulty. I've just done a very large piece of work for somebody else, not in this country, somewhere else, on finding tools that work, mental health. I'm working with blue collar workers, people that work in factories, on what that does. And the tools you use for one set of populations is very different from what you'd use for another set of populations to case find. And I think we need a framework for that. So just to make sure that we're using the right tools to case find people, you can't put the interventions in place if that doesn't happen. So I guess I'd like to see very much more of that. That's why our public health doctors, I guess, are there to do some of this.
Thank you, and thank you for highlighting some of the positives. I guess it would be wrong of me to sit here because the top one is waiting list. I know stated there's a lot of work on it, and I guess just in terms of given that SAP had these aren't numbers, these are patients that are impacted both whether it's work or in chronic pain. But in terms of SAT from the summer, our waiting list has gone from 50,000 down to 42,000. Waiting over a year has gone from 4,000 and we've got 1,500, which we hope we will clear by the end of the year. And I guess for anyone on the 5 weeks, we had 1,000 in the summer, and we hope by the end of this week we'll have none. So it is difficult to do this anyway, but when those numbers were so big, it is really challenging. But I just thought it's helpful just to that did have a large amount of those that came out of
Nigel, Tracy, really appreciate this. Thank you. I think a couple of reflections from me. I mean, I think the report covers a lot and really starts to bring to life the amount of work that's taken place, which is fantastic. It does feel as though this is much more business as usual in conversations and in discussions, and that's a really positive thing. It's no longer we must do it and it sits over here. It's actually a core part of business, and that really adds value to it, I think. But it's also really helpful for the board to see in one place the breadth of work that's taking place and the progress that's being made, because it's not, we recognise getting started on this was one thing, getting started and mobilised with the resource and with capacity and make it mainstream was another. Being able to do that and then show an impact in terms of residents and people, because let's remember at the end of all of this, this is about people, isn't it? And your conversation then, Tracy, in terms of saying, you know, how this comes then through into the place boards, into PCNs, everything that we've just been talking about. We need to make sure that we continue to hold on to that as we go through the clustering arrangements and we move to a bigger footprint. So it's that bit of let's not lose the local neighbourhood piece as we get into the next phase of the reorganisation. But just wanted to say thank you to you and the team for the work on this, because it's really comprehensive and covers a large area and is increasingly impactful. So thank you.
Okay, well done, Trace. That's a brilliant report. Lots of food for thought, and we'll no doubt come back in due course. Thank you. Okay, moving on then to intensive and assertive outreach. Riley and
Sitting behind this chair. Oh, just find some space for them somewhere and. Take recordings. Yep.
yeah.
Thank you, Chair. I'm Cathy Bradley, I'm Managing Director of Shropshire Telford and Wrekin Care Group in NHS.
And I'm Jo Johnson, I'm Quality and Governance Lead for Telford and Wrekin Commitment.
And Jo has been very much involved in a lot of this work. This report provides an update regarding progress made against the action plan in relation to the CQC special reviews done in 2024 of mental health services in Nottinghamshire, and also incorporates the more recent recommendations following the independent mental health homicide review published in February 25. All of these related to the tragic deaths linked to powder cocaine in Nottinghamshire that people will remember. NHS England requires this report and specifically the action plan be considered by all ICBs by the end of June, so that's why it's reviewed today. NHS England confirmed in April 25 that additional funding would not be available in 25-26 for this work, and systems were asked to prioritise actions that providers could implement without additional funding, while acknowledging that some actions will require investment, and so implementation will vary across providers and occur incrementally over time. It's important to view the action plan in relation to that guidance. The report outlines the actions taken and either completed or due to be completed during 25-26. The cohort of patients, and these are incredibly complex mental health and vulnerable patients, have been identified, and we've currently got 75 service users open to us who meet this cohort. And enhanced monitoring is now in place to ensure that they are not discharged and that care is being actively delivered. There is a good level of assurance about this part of the action plan, and this is overseen by the Midland Partnership Foundation Trust Quality Committee. There is also a system level task and finish group that continues to review and develop the action. However, full assurance cannot be achieved yet, and this was reviewed by our board. And that's because risks remain that we are as yet unable to deliver care under intensive and assertive model, because we haven't got the capacity, and we wouldn't be able to meet the new guidance which says that caseload should be circa 15. And there's also that there's a risk that there may be further identification work required within the system. And both of these risks will be further looked at by the task and finish group. And the next incremental work will be led by the ICS task and finish group. It's also important to note the task and finish group is utilising QI approaches. So we've got a small pilot happening in South Shropshire to look at what future models would work well. So in summary, the ICB is asked to note the report and its recommendations, including the action plan. We're open to questions.
Okay, thank you. The questions for this.
You have an EIS service. How does this tie in with the EIS early intervention service?
So the early intervention, we've got an early intervention service in place. In fact, it's one of the few accredited by the Royal College of Psychiatrists that has got the caseloads of 15. It's a good service. We've also got another element of service that would support this cohort of patients, which is the rough sleeper group. That was implemented, team which was implemented about 2 years ago. We've got elements, just haven't got a full intensive and assertive outreach model.
What would you need for that? Because I guess the recommendation is here is you can't do this without further investment. Did I read that correctly, or am I making it up?
No, but obviously we are doing what we can. And
So I get that.
Yeah,
And you can do what you can.
So NHS England did ask systems to respond to an idea of the level of funding that would be required, and we have submitted that. But we're not at that stage, and it needs some further review work now that we've done the work to date. And we've got, you know, exactly what the number of patients are. So that will be something that will be brought back to the ICB when we've got the work done around that.
Thank you.
Vanessa.
Thank you very much for the report. It's really clear, and I think that's what was needed. Can I just check on that, just following on from Nissy's point really, that the actions that are in place are adequate to mitigate clinical risks sufficiently at the moment, all being that it's a stretch and that financially there's challenges?
Yeah, so we've got some really good oversight of what's happening around those patients. And that happens at the service level, care group level, and then right up to our board through the quality committee. What we have got patients that are being held in our general community mental health. So there may be some specialist teams that Nick referred to, like the early intervention team, hold some of these patients, but they are sitting majority of them in general community mental health services. We've got much bigger caseloads than 15. But we do feel that we're able to provide a level of care to keep them safe, but we can't provide intensive assertive model that's needed. So we've adjudged that within NPFT that we're holding a sort of level 12 risk around that at the moment.
One question, what's the national picture across mental health trusts?
Yeah, so I think it's going back in time, but I think it was roughly about 2012 that intensive assertive outreach team were remodelled, and we changed to a different model in mental health services. The majority of systems do not have intensive assertive outreach team. I think we've got one in Sheffield, might be the closest that we've still got remaining to us, but the majority have not got it. So our position is very similar to others.
But it's what's recommended by the college, isn't
Yeah,
it?
there's new guidance that's
Yeah,
now come out.
I saw that.
There's all the recommendations come out. So we'll work into a lot of new recommendations around it. You'll see that some of the actions in our action plan are linked to that new guidance, like safety planning. This happens, so we're working through that. That's why it's still working in progress. I think the safety planning part and safety suicides came out maybe 2 months ago. So there's a lot of change in this space.
Helpful, Kathy, Neil, Joe, in terms of setting this out. I mean, it's really important that board members are fully cognizant with the action plan that's in the main pack of papers under Appendix 1 and the action being taken and the mitigations in there, recognising that the context that Kathy's explained it in is clear and understood, but also the progress that is being made and the work that is happening in that space. So just make sure that board members are fully cognizant of the detail that's in that Appendix 1.
Excellent.
I just make a suggestion just to come back in that this is such an important issue and has had, huge national discussion around it. I think it's really important that we keep a really close eye on this, and suggest that it comes back to the Quality Performance Committee, and we'll decide on a regular basis what sort of regularity with Kathy that comes back, so that we keep the board updated by that.
Good point for that, thanks.
Chair, I think there may be some requirement that's just recently come out that I think I might need to go against September time, but I'll clarify that.
Okay.
Thank you, Kathy.
Thank you. Any further points? Good. Thank you both very much for your presentation. Well done. Thank you. Okay, next item is the finance.
Chair, I'm really pleased to be able to present today a refresh of the system's finance strategy, medium-term finance plan, and also a long-term trajectory to that finance plan as well. Grateful for the support from system colleagues to be able to do a comprehensive job on this, because we needed to refresh what we had in place already to reflect current circumstances as they are today, although noting that the world continues to change around us. The documents here that you have for review, from a strategy point of view, we set out our ambition for how finance will support our strategic intent as a system. And from the medium-term finance plan point of view, that document is really important because it highlights how we return to a stable underlying financial position. We deliberately run a long-term model alongside that because we know that HTP is one of the fundamental elements of our strategic programme moving forward. So we wanted to make sure that our assumptions that we captured in finance ran on and beyond that programme of work, just to be sure about our clarity of that financial trajectory. What you'll see in the document, I believe to be an ambitious plan. It's not without its risks, don't get me wrong, but this is a really strong foundation from my point of view, where we can agree a point that we can move on from. And certainly we're recommending sign off for a trajectory between now and 27-28, as I say, that returns us over 3 years to that position of underlying balance. The efficiency programme in there is round about 85 million pounds with current efficiency required each year. Not insignificant, but actually we demonstrated that we can do that. We've got a strong programme in place now. We've got a good view of where our opportunities are and a good run into that pipeline of work that we require to deliver the level of efficiencies we describe here. I'm pleased to say that both of these documents have been socialised extensively. It feels like it's been doing the rounds for quite some time now, but for good reason. We wanted to make sure that we got these right. So certainly through system governance, multiple times through finance committee, our strategy working group, our strategy committee, we wanted to make sure that we got the best connection from that finance strategy through into our other strategies, and particularly around the joint forward plan. And I'm also grateful for finance committees in our partners or their equivalents for allowing me to indulge and come and talk to them about what's in here as well, and really have the opportunity to keep this information around to make sure that we're all clear about what's in there and that we can all own it. And all feedback that we've received, whether that be through conversation on the day, I know I received a letter from Shropcon which we've responded to, we've incorporated either into the documents or into our work plan that falls out of these documents. These are not going to sit on a shelf. There's a lot of things we need to do, and so my next job as of Friday is to sign off that work plan with our system directors of finance so that we can then clearly push that out across the system for delivery. I can't ignore the fact that we're going through a government reset programme. We also know that we have the 10-year plan on the very imminent horizon, and following that we're expecting additional planning guidance, operational planning guidance, allocations. So I'm under no illusion this will require a refresh, probably late summer, and certainly we intend to do that. We've also got a lot of really exciting work happening through the summer for our own modelling. So we're having another look at the HTP modelling alongside partners at SAS. We've got a lot of exciting work coming through the healthcare models group, which we're aligning with that. So our demand and capacity view will all be fed in to refresh the modelling. And our transformation plans, system transformation plans, are continuing to develop at pace. So we'll have lots more to feed into here. These are key items of evidence as well in our work to exit the National Oversight Framework Level 4. So these aren't just about setting out our ambition, they also enable me to provide the evidence that we are collectively committed to drive that financial improvement. So that board sign up today is really symbolic for me of how far we've come in terms of getting behind this financial trajectory. Really, really important for me to put forward as that evidence. As I said, these aren't going to sit on a shelf. We've got our action plan. The medium-term numbers are not going to be left through Finance Committee. We do take an interest in our underlying position. That will continue through the year because obviously if that deteriorates, it impacts on our ability to deliver future years. We've also promised to bring back the developing modelling work through that committee for review, and also we'll be bringing the action plan updates there as well. So through Finance Committee, we can bring future updates to board. I'll pause for breath there, but I'm hoping that today we will be able to approve as a board the strategy, medium and long-term finance plan, and then note the fact that we will bring further updates as we have more input into the model as things develop.
Claire,
thank you.
Very good summary. Any questions or points to raise? We had a board development workshop on this topic not long ago. Very detailed discussion. Andrew.
Thank you. I think I can ask this question as the SAF chair, and nobody can throw things at. Some parts of our system do not have a glorious track record of delivering financial plans that they signed up to. Why would NHS England believe?
I think the thing for our system is about developing credibility, and credibility is achieved through doing what we said we'd do. So accepting that in the past we have had issues with delivery, what we can see, particularly through recent months, is an ability to be able to deliver what we set out to do. And I think that's why the planning round for 25-26 has been so crucial in this. We wanted to set ourselves a plans that would challenge us, but would be realistic in the context of laying the foundation year for that delivery of that longer trajectory. We were never going to be able to get to break even in 1 year. It's just not an ask that we could have signed up to. To earn the ability to have a multi-year programme, that's been the whole crux of the conversations we've been having. It's got to be
Yeah, I knew the answer to my own question. I suppose the key bit is making sure this year we do actually deliver what it is we said we would deliver. And at month 2, that's looking a positive position. I know it's only month 2, but you can actually muck up month 1 and month 2. So we haven't done that. So my second question is, in terms of your discussions with national colleagues, I keep reading about an end to sort of deficit funding. What's your sort of gut feel for actually they will go for a 3-year, not a 2-year plan?
There's some interesting debates going on at the moment about the end to deficit funding. I think there will be an end. I'm not questioning that. I think what will be interesting is to see how strongly we are pushed in terms of what's called the distance from target. So as a system, we're deemed to be over target, i.e. we're consuming more of the allocation than we should for our fair share. We've done some work in the background based on what we know now and based on assumptions around what the ask might be in terms of trajectory to fair shares. And at the moment, the plan as we've modelled it would more than adequately cover that requirement. Obviously, that's only based on an assumption of what the rules might be, and that may change, which is why we need that national guidance through. But certainly, if you work on the basis that all systems would be required to be within a 2.5% tolerance of their fair share target, which is the rules at the moment, this would deliver us to that at a reasonable pace that would fit with that. I can't say what will come out in national planning guidance though.
Andrew, in terms of your first question, the other piece in that is to ask, almost turn the question around to say, to ask for your help. Because the boards will be the units of accountability in terms of delivering the various aspects of this. And our strength, as you said, rightly, and as Claire reinforced, is we deliver month one, we deliver month two, we get quarter one, and we build from there. And so boards having a very clear oversight of their accountability and their responsibility and bringing that to bear in terms of supporting exec teams and ops teams, clinical teams to deliver is ever more important in that space. So the reason for bringing this here in terms of that system space is that everybody has that conversation. That's also why Claire colleagues have been doing the tour of finance committees to bring that to life and provide finance conversations as well. The other piece, if we think about the potential publication of the 10-year plan will get published potentially next week, and the indication of the 3 shifts in there. The other piece that we need to be cognizant of, so to recognise we're signing up to, is a shift in the way that an indication of a shift in the way where we spend our money, and this indicates that shift to move away from acute spend and to redistribute that into the community and primary care basis of that spend. So that is the direction of travel that, as the Commissioner, we're starting to say, this is where we want to be going and this is what this looks like. We absolutely recognise that we can't do that and just leave services stranded or with stranded costs in that space. So that's got to be done in partnership and at service level in a way that's agreed with all of the neighbourhood work to underpin it to get in the right place. So everything that we've been talking about in terms of health inequalities, prevention, public health, absolutely a key part. But this document indicates from a strategic commissioner a direction of travel towards a smaller acute sector in terms of money and activity and a stronger community-based approach to health across Shropshire.
Just come back on.
Come back to it.
Thank you, Chair. Just a couple of points. One, following Andrew's comment, actually, in the press today, it looks like 2.2 billion has been going to be allocated to cut in the role of reducing care inequalities, and the deficit reduction will be, instead of being placed with trust, will be placed in that area. So that's reinforcing your point. But it looks like that's hit the press. Well, it has hit the press today. But my main point was relating to, I guess, the ambitious savings associated with this finance strategy. It is ambitious, and absolutely to Andrew's point, we need to see delivery, which is reinforcing your point around credibility. The main point I want to make is around CHC. I won't be able to support this if there's any change in policy that affects our residents in any way, shape or form, because the biggest chunk of savings is relating to CHC in this plan. And the other element of it, so not only not affecting our residents in terms of policy, but fundamentally no shunting of costs to councils. Those two things are really important to us, and I require assurance around those elements before I can support this.
Yeah, happy to come in. Thanks, David, for your comments, and recently you've written to us and we've responded to that as well. The CHC savings are almost entirely on a quality-led trajectory. So everything we are doing is in line with the national framework. We have taken the approach that if we assess people on time within the targets required in a quality way, then that leads to further assessments and reassessments in a timely way, rather than stopping, many years down the line and expectations, which I absolutely understand would result in a cost shunt. We're working with the local authorities on that approach. Social care teams are working really closely with us. What they're finding is that we're refining some of the processes which are helping them to get to people quicker in a more collaborative way. So I'm really cited on your concerns, David, and we'll keep a really close eye as we deliver those savings and carry on and obviously stay in touch with the directors of adults and children's services.
I think just to reinforce, Chair, sorry, is to be really clear in terms of what's that exchange. Our starting point here is do the right thing aligned with the national service framework, and do that in a timely and effective way, but do that in partnership. So this is absolutely not about saying this becomes somebody else's problem. This is about how do we get a really quality response to individuals at some of their most difficult times in their lives. But we do that jointly. It's not about how do we cost because that's not where we're at in the partnership process.
Is that okay?
Yeah, fine. I guess my response will be, thank you for the assurance, but there'll be a watching brief around this, obviously. And I guess the thing that concerns me the most in terms of what I've seen so far in terms of activities, the retrospective work in terms of residents and what that will mean to those individuals. And I think that's where it's going to be a bit difficult in the short term, but we need to do that together. It can't be the councils leading that change.
Okay.
Fine, thank you.
Andrew.
No, it was just to give Simon the assurance that if we sign up to a plan, we're very clear, both boards, that you do actually deliver those plans, not just financial ones, but the other ones as well. And the second confirmation bit was just on the sort of acute to care close to home. Absolutely, that's got to happen. I think that's been talked about for decades now, hasn't it? Particularly failed to do that. So we are, again, both boards committed to making that happen.
Thank you.
It's a quick one, Claire. I guess you have no control over some of this, is my feeling. I mean, if politically we've decided to cut down the waiting list all of a sudden, I have been there before. I'm so old I can remember that. And when that happens, it throws all your financial plans out of order, right? And we don't know that yet. No one has told us that. They decide what to cut our waiting list down to 3 months or whatever it is. That's a huge investment. And there's no new money for that. So I think you've done what you can in the current framework that you have. So thank you very much. But I think, again, this has got to be a watching brief because actually, you know, what's going to come at us, we don't know.
Yeah. And I think that's the nature of this model. And to be honest, it's the way we built it without getting into all the technical stuff. What we've got is a model where we can not just kind of look retrospectively and then use the spreadsheet to chuck the numbers forward, but the work over the summer will help us to produce some scenarios as well. And we'll start to kind of stress test some of our assumptions. So, you know, how far can we push this work in the community without HTP falling over? How far could we, you know, build improvements in our waiting list performance, say, without impacting on the bottom line? I think the other really important thing to flag is that we also have our strategic decision-making framework. At some point, we will have to come back and we will have to consider some of the hard decisions we will need to take. We're in that territory now. So for me, it's about making sure that we've got that live consideration and that our processes and governance are in place for us to be fleet of foot in some of that decision-making, but also safe in how we do it. So I think I've said this here before, that decision-making framework is not a finance tool. It looks at quality, it looks at patient impact, finance sits alongside it, because if we need to make some informed decisions about what we have to prioritise because the money doesn't go a long way, then that's what we'll be doing and that's what we'll be using.
Any final points? Okay, so with due regard to all the very good points made this afternoon, are we prepared to approve the ICS finance strategy, medium-term financial plan and long-term financial plan? Subject to the point that it may change in the next.
Yeah.
Okay, thank you.
Thank you.
Thanks, Claire. Moving on then to the next one, which is the people strategy. Stacey, you picking up?
Yeah,
Okay.
thank you. Thanks, Chair. And yeah, bringing today again for approval is a refresh of the system people strategy. So we've had STW people strategy since May 23 that was approved, but again, different landscape. Obviously, as a requirement as part of the system integrated improvement plan, but also links to the review we commissioned in January of this year around people services. So So what's here today is a refresh of priorities over the next 2 years. Deliberately high level, but focused on elements that will have an impact, a direct impact both on workforce efficiency, but also the quality that our staff receive at work. Within the strategy, we've outlined the delivery model, existing governance arrangements, but again, similar to the finance, we've got to remain agile to emerging trends and themes. So we know the model ICB blueprint, running cost reductions, the long-term plan, and we know that there will be a refresh of the long-term, the NHS England long-term workforce plan as well at some point. Again, lots of engagement through different forums within providers across STW. Moving forward from a governance perspective, we've already aligned project initiation documents to each of the 4 strategic themes and each of the work stream involved there, which will be overseen by the people collaborative reporting through to the ICS people. So happy to take questions, but again, being brought here to approve.
Yes, Stacey. Questions, Stacey, on.
Sorry, I mean, I've been involved in this work, Stacey, not Stacey, you, but I mean, I guess the key bit is from here or outside of here, how does it translate through into organisational people strategies so that it hangs together? Because otherwise it's fit for as a strategy and it'll fit with the committee. And then organisations say, hey, we've got our people agenda and we're doing this, this and this. So I can see a line of sight, but it's useful just for the board to hear the assurance from providers that actually there's a concerted effort to pull all this together in one place.
It's certainly been through Robert Jones' people committee. I know Ria, whether it went through your committee, Joe, Patricia, but I know it's certainly been shared with other providers, but as well through the collaborative. We have voluntary sector, our education, local authority colleagues. So certainly from a provider perspective, this is built into our own sort of people strategy.
It has been throughout as well.
Any final point?
How does this pick up any gaps that you might be finding are emerging? How will this strategy pick that up?
Yeah, we've done a fair bit of work to try and scale down what the people people are doing around this piece of work, but at the same time doing work. We've got lots of transformation projects across the system. A lot of it's around pathway redesign, and the workforce element needs to sit there, not in separate. What the system PMO are doing for us, because we've asked this around how do we link all that work across. So I still think we need to sense check, are there gaps? So we've looked at fragile services, etc. But we just need to make sure with the PMO support, we now have far better oversight of all the work that's happening in different areas across.
Thanks, Stacey. And my final comment will be around digital. How are we using digital to support your people strategy? Because where I see it, I work with lots of different people. It's community. I've just trained about 50 pharmacists in Nigeria. I've just come back last week to take on 12 care pathways. And, I can do it in Nigeria. I'm sure it can be done here. So it's about using digital, using point of care, using labs differently, using digital services differently. So I don't know. I don't see it here, and I don't see us linking that to digital service.
You speak when people professionals, that is all they say.
Okay.
Better digital. We need better digital. Because they think from an efficiency perspective, administration perspective.
It's also decision making. So if you can get a decision made at the pharmacy where people go for their headaches or their tummy aches, that's where people go, right? I'll get the appointment with the GP, that's where they go. If they end up there, how do you make that decision quickly and easily, the right decision, so you don't miss the stuff that you can't miss? We really do need that embedded here, and I think it's a big part of what we do, but we don't see it in any of these strategies.
Something I've
Sorry.
really taken away with this, and I think looking again with the piece of work we're doing around shared services, certainly if it comes to people, but I think it's far wider than just the people.
Yeah.
Yes.
Good point. Thank you. Okay, so we're happy to approve the people strategy. Thanks, Stacey. Right, conscious of the time, we're a bit of a marathon session. Do you fancy a 5-minute break? Okay, so reconvene at 3:30.
mine adopted and other views. But it's all a waste of time. I won't listen to much.
Always think about.
I'm sorry. So I'll keep it brief. So thank you for reading the report. Let me just draw your attention to the recommendations at 1.2.1 at the risk of repeating up the whole contents of the report, but draw your attention to the Arthritis Musculoskeletal Alliance report presented by Sue Brown, the allocation resource framework, there was commitment that there would be further development work around that and then to bring back to a subsequent meeting of SHIP. Pharmaceutical needs assessment was then presented and would latterly go to Health and Wellbeing Board to be hopefully approved for consultation. Health Watch report was received again around pharmacy services in Shropshire. There was a BCF update, which would then go to the Health and Wellbeing Board again for approval. And then please note that the neighbourhood working hub subgroup, excuse me, with the change of name, much easier to pronounce would be the SHIP Accelerated. Those were the recommendations to note to the board, Chair.
Thank you. The questions for?
Not a question, Chair, but just to update as co-chair of the Health and Wellbeing Board, I can confirm that the pharmaceutical needs assessment was approved for consultation at the Health and Wellbeing Board and that the Better Care Fund was signed off at the Health.
Thank you.
What is the SHIP Accelerator Group?
That's the rename of the previous group. That's simply on the
So it's not a real accelerator.
Of course it is. That's the idea behind it, but it's the rename of the group.
Accelerators are money and they have like people that do acceleration of what they're doing. Is that what that is? That's how I would view an accelerator.
I think that would be the intention.
Okay. Okay.
I think that's please answer that, Chair. Yeah. I think just working with through Andy's care of the place forward, the subgroup is where we've really got some of that detail happening, and we're trying to refresh some of the mirroring that we're doing in TWIP, looking at what are those areas that we really want to focus on the priorities in hand, and as per Andy's update, we're really trying to make sure that we've got the priorities that have been identified at each place translated then down, because obviously place forward and we trying to receive that fluence and understanding. We need then those working groups to make it all happen. Yeah, what we are doing certainly with both places is also cross-referencing that system-wide priorities at work, and also as Jason and Ian and others are looking at, for example, risk classification, how we then deploy some of those methods.
It doesn't have money attached to it.
It inherently has, with some of the capacity.
The risk stuff that's attached to the PCN is part of the PCN DES, so we have to do it. And yes, we get money for doing the DES, but there isn't. That's money that we've had each year. It's not an increased amount, if that makes sense. So it's part of our core contract, PCN.
Okay, so it's not money to accelerate new stuff or old stuff or whatever it is. It's money that's already there. That's been. Is that what it is?
It's something that we have to do to get our money, so it will happen.
Oh, I see. Okay, thank you.
So we had teaching on Aristotle, and I think each PCN probably going to. I think there's some potential projects that we're looking at with sort of the winter planning and UEC area, but also I think each PCN is probably going to approach their own risk justification elements. So like after today, like certainly we'd be looking at we're going to look at frailty anyway, but I think for us we can look at risk justification with those frailty patients over a year and how that cascades down and stuff. Try and integrate with that. So that individual PCNs will do something, but something new will have to happen with risk justification for us to get our money. And we need the money, so we're going to have to do it. So, yeah.
Risk stratification, that sounds really good. Is there going to be some kind of agreement around what type of risk stratification tools
other providers can link into that. Tony, our services or Joe's services.
Yeah, so the tool that we've been shown by Craig is the Aristotle stuff. I think that's what is being proposed that we use. There isn't anything from NHS England in terms of you have to use this. There's also no clarification from NHS England in terms of what we have to do. It just says use risk stratification, you know, to do some good. So it's quite nebulous, which actually is quite nice because it can do something. No one's looking at me. I'm just hoping that I'm not having just my point.
No, not at all. No, not at all. Just to add a bit of detail, so Aristotle is fed by the combined predictive model of risk stratification of risk prediction, and is it predicts risk of non-elective hospital admission.
Yeah,
at the moment.
so that's what it does. It doesn't really predict anything else.
Yeah, exactly so. Exactly so. So we'll start with that tool because we have it available to us now. But part of the conversation that we need to have is, what do those other tools look like? What options do they provide? How do we align with provider partners? How do we make sure that we can predict a range of risks that are relevant to the challenges that we have? And that's part of the ongoing conversation, digital conversation. The digital delivery group is discussing that and as are the clinical folks. So
if you want to have an offline conversation with me, I've just done a whole analysis of these tools.
Yeah, that'd be really helpful because we've got
I just we wanted to have a separate discussion around risk stratification and all this stuff. That'd be helpful for you. See how it works. David.
Thank you, Chair. Just to reinforce 3 points for May under 1.4.2. The third bullet point is around the significant amount of work around place prevention funding. Several projects have been prioritised by the group, over 300,000 investment in those, so delighted with that work. The fourth bullet point talks about the communication engagement plan for the first theme agreed by the committee, which is around the focus on vaccination. We'll launch that in August ahead of the vaccination clinics for flu and COVID, which will open in September. So that's reinforcing Simon's point from earlier about using all organisations across the system in terms of their connections from a comms perspective to reinforce messages. And as I said, the first one is around vaccination, so pleased with that. And the final point I want to just reinforce is the fifth bullet point around the optometry programme, which goes live next week. We were delighted to see this work come forward, respond to concerns raised by residents, and it provides a shift to services to the community closer to home. So delighted with that work. Thank you, Chair.
Thanks, David. Good news on the optometry. Thank you. Any questions for David? Thank you. Moving on then to integrated care system performance.
I'll take the report as read, and in the usual style, what we've done in the executive summary is try to pull out areas where we're seeing improvement, also the areas where we're seeing continued concerns. I think for our improving areas, the point that I wanted to make was kind of links to the discussion we had about the medium-term finance plan. Sustainability is the key with these indicators, and we need to see sustained improvement to make sure that we're getting the best out of the investment into the services that we've got. With regards to finance, again, we've touched on this a little bit already today. I'm really pleased to say that as at month 2, we have delivered to the plan that we set ourselves and signed off at this board. So we've reported a 1.8 million actual deficit to plan, but actually that's about 655 better than we thought we'd be at this point. Predominantly that's through the efforts of our continuing healthcare team, who've managed to secure a really good early advance on their efficiency programme, so it stands in good stead for the rest of the year. But efficiency delivery overall, again, we're performing well against the programme of work. I have nothing to escalate in terms of capital expenditure at the moment, and the programme of work is well underway. We make sure we get every little bit of benefit that we can from the funds that we're given. So if anything changes, yeah, just to highlight, we'll bring those later in the year. And otherwise, I'm quite happy to see
For
ADHD.
Yes.
That's all on everybody's side. On ADHD, it continues to rise everywhere. We are not an outlier compared to anyone else. Are we still going down the route of physical assessments? Because there are so many digital tools that reduce the actual diagnosis time, and the accuracy is quite amazing. So I don't know what we're doing with those.
Yes, and Nish mentioned this in committee the other day, and we agreed that we catch up outside to have a conversation about how we might deploy those tools, because yes, we are still utilising physical assessments, and actually we've been very clear in our use of providers that we mandate at the moment is face-to-face assessment on the basis that there are so many right to choose providers where it is a remote assessment. However, recognising that the digital assessment is a different thing again, I think we need to have that conversation and see how we can actually.
I can just help you with that. I can put you in touch with people so you can see, because there's a couple of leasehold practices that are starting to use it already.
Yeah, that'd be really helpful.
Okay. Any other points clear?
Sorry, can I just jump in on that for one point there? ADHD assessments digitally. I actually had a digital assessment, assessed digitally for ADHD only just 2 months ago, and it was through my original appointments. Everything was all through the NHS, and I had that done. And there's some paperwork that came across, etc. And there was a process, obviously, and that was done, and it was done, I think, incredibly well, in honesty. And I think it saved an awful lot of time when it got to that point. And I think it worked really, really well. I've gained a lot since then as well, but I've managed to learn ways to manage it better, etc. So that's just me personally saying that.
Okay, thank you. Moving on then to the next item, which is Equality, Diversity and Inclusion Update Report. Vanessa.
Thank you very much. The paper that gives progress reports with the background that the public sector equality duty is the responsibility for public sector authorities, but we also have a collective responsibility as an ICB board. So the update is following previous reports and papers brought here, in which we decided to develop strategic objectives for the system. Those were approved at the last paper, and this is listed as a reminder. The ICB decided to concentrate on item 6 as a priority, which is to build an ICS that celebrates diversity, empowers change, and recognises the impact of our health and care teams. And we decided to involve strategic partners to support further improvement. We met in February, quite a while ago now, as an away day, a board development session facilitated by that provider. And what came out of that was 3 projects. One was about consistency in the application of our policies and processes, particularly in relation to race, as again decided as a priority area. And the second was to have a coordinated communications campaign targeted at professionals, but also to the public as well, so that we really do celebrate that diversity amongst our health and care staff. So both those things were deployed with a 90-day improvement model, and I'm pleased to say the updates provided in the appendix. There was a lot of rapid work went on, and grateful to Nigel for co-chairing with me the groups that led this. Most boards in the system have now had a conversation about how incidents of racism are reported to the board. Where they haven't been done, they're planned. And we're, again, grateful for that engagement. And I think there's been some really interesting conversations that have come out of those board level discussions and that have been fed back. And we've put a flavour of those in the appendix document for you to see. So we've really feel that we've upped the communication about racism, that boards are committing to take regular reports on the numbers of incidents. And I think one of the big areas which we would not be alone in is about driving up those incidents and the reporting and the value of reporting those incidents. And that's something that the EDI steering group, as the operational group behind this, are really committed to as well. The second area was around the coordinated communications campaign, and I'm really pleased to say this was launched in May. It was launched on World Day Cultural Diversity, which is 21st of May, with a really brand new comms campaign with nice new graphics, with mainly digital to start with, but that is now going into posters and other media. And this afternoon, email straplines are being launched. So there's a constant plan of when we can launch different parts of it. As part of that, we asked our health and care colleagues to engage with us and to see whether there would be any of them that were kind enough to want to contribute to that by telling their stories and actually featuring in some of the materials. And I'm really pleased to say we've had a fantastic response to that, and that around 12 people have already been photographed and similar number are waiting to be met to contribute. So that's something that we wondered was going to be achievable, but actually that's happening now too. So this is a long-term campaign. We're going to agree with the EDI steering group about maybe 3 or 4 key campaigns in the year where we can really change it and adapt it, and also expand away, keep the race theme, but actually move into other areas of the EDI agenda as well. So really, I'm asking for your ongoing support. We'll be analysing these campaigns. We'll be bringing that analysis back and looking at where else we can publish that going forward and sharing that with you. And the steering group will also be looking at which of the next objectives we'll be looking, we need to look at next, and I'll be bringing that back at the next report. So the board to note the report, please, and support further work.
Thank you, Vanessa. Any comments, questions? Well done. I mean, this is a hugely important area, and I think the idea of having regular new fresh campaigns is critical. Yeah, thank you.
Well, thank you to all the work from the partner organisations, to be honest.
Thank you. Let's move on then to the information governance, direction and travel.
Thank you, Chair. So very briefly, time of the year where all organisations are about to submit their self-assessment against the DSPT, the Data Security Protection Toolkit. So this is the framework that we judge ourselves against and how well we govern the information that we hold, we share with others, to give assurance to the public and patients that we're doing that as per legislation. There is one part of the DSPT which is new this year. It's been realigned with the CAF, the Cyber Assurance Framework, which is really, really helpful because they've sat separately in previous years, and it's been very difficult to have that read across. But what that's meant is that we've had to do a reassessment of the evidence that we have to submit, because there is slight subtleties in the approach that we need to take in the evidence that we give. So our internal auditors, the ICB, have highlighted that there's one area that we need to think about, which is a new area of the boards of organisations giving a very direct steer in terms of how they want IG to be approached by their organisation. And despite the plethora of policies, etc., that we have in existence around IG, that our internal auditors didn't feel that it met that new requirement in sufficient level for us to be compliant. So what I've presented today is a statement, a direction of travel statement, which is the wording that's used by the guidance from NHS England around this area for the board to adopt today, so that we can be compliant with that particular area of the DSPT. What I would say is that this is not a new approach. I've drawn this from our current policies, but I'm just bringing together a very high level strategic statement around the board's approach to IG, what we expect of our organisation, how we expect information to be governed and managed appropriately, and the objectives around that, what we want this to do. So I hope that that's acceptable to the board, and I'm asking for approval of that statement, Chair.
Thanks, Alison. We're happy to approve.
Thank you.
We should go in that direction.
Okay, thank you. Moving on then to the next item, which is the committee reports, quality performance.
Very much. I'll take the reports read, but just highlighting a few points. So the committee was really pleased to receive the information that MPFT's CQC rating for adult acute wards and psychiatric intensive care unit had increased to good across all domains. We all know how hard work it is to achieve that, and the dedication and commitment that's required by the staff. So thank you. We received that. The urgent and emergency care and diabetes remain the two highest risks that the committee is monitoring, and both are scheduled in for updates currently. But there is urgent emergency care moving on, but diabetes has been a really slow start for that improvement journey. So we are raising that as a point of concern, but we have got the meetings tomorrow, the committee, and we have got an update there, so we will see what happens there. The performance and assurance section 1.4, just to highlight the improvements which Joe's actually already alluded to in plan care, but also in cancer as well. And finally, maternity smoking at the time of delivery is now showing sustained improvement of less than 6%, which is excellent achievement.
Any questions? Okay, thank you. Move on. Finance committee, Dave.
Yeah, so the reports are in there, but they're for meetings that are out of date now, really. So we had our meeting yesterday afternoon and reviewed performance up to the end of month 2, which across the board is quite positive. The headlines being that the ICS reported a 1.8 million deficit at month 2, which is although it's a deficit, 655,000 better than plan. Efficiency at the end of month 2 running at a delivery of 20.7 million, again 4.9 million ahead of plan. Capital is running slightly, operational capital is running slightly behind plan, but that's simply a question of timing and the elements that have caused that target to be hit will be delivered in the next couple of months, so that should remain okay. The one issue, in terms of digging at the numbers, the one issue that does remain is the escalating bank costs. We do need to take a view on that. We are going to be measured separately on delivery of our bank cost targets by NHS England, separately from whether we hit the plan or not. So we do need to get back onto managing that. We looked at SIP, and I think it's true to say that we are really significantly ahead of where we normally are at this point in time in terms of the planning for SIP, the delivery of SIP. We have £74 million worth of schemes that have moved into delivery against a target of 95 million. And as of the end of month 2, only 5.7 million pounds worth of schemes were rated high risk. And given that we were still managing high risk programs out of the system back in month 10 and 11 at the end of last year, that's a tremendous performance against a very challenging target. We looked at, as Claire's mentioned earlier, we looked at the medium-term financial plan and the finance strategy. One of the things we have, obviously, we have our own separate operational plans for 25-26. And the important thing about the medium-term financial plans, we will do a deep dive come the autumn, in particular looking at our exit position, our underlying exit position as it builds up for across this year, to see whether we are exiting 25-26 in the position which will allow us to deliver against year 2 of the medium-term financial plan. That's pretty much it. We hold one thing we should definitely call out is we had a deep dive on efficiency and the PMO view on efficiency and transformation. And I think the committee took substantial assurance. The presentation that Kate gave was, and indeed Trevor as well, thought was excellent. The level of control over the delivery of the SIP and the system transformation programs, as demonstrated by the deep dive, was absolutely excellent. It was, and as I say, having seen a number of other systems, it actually was. I was thinking very much that I wish we could have some of this stuff elsewhere, because that was really good, really good.
Thanks, Dave.
For a small fee.
Yes, that's right.
A large one.
A large fee.
This is a good start. There's financially lots to do, but congratulations to everybody in touch with the effort we're getting. It's a positive start. Let's continue that good work. Thank you. Right, moving on then to the next one, which is the
If I may, Roger, it's very mundane compared to that, but there is an ask in the paper. The committee did make some suggested amendments to its terms of reference to remove the areas that used to fall under section 1 committee, but have now been moved into our new committee, Commissioning and Productivity Committee. We will be bringing a further update in September to put us in line with some recommended everything, but just to capture the agreement for those so that we're up to date as we can be.
happy to approve the tidying up.
Thank you.
Thank you. Yes, going with that. Right, People, Culture and Inclusion Committee. Stacey.
Right, yeah, I'll take the chair's report as read, but it was the report from the meeting that held on the 16th of April. There was a committee last week, but just due to time, that's but I'll take any questions. Nobody's already yet.
Any questions? Yes. Moving then on to the specialist commissioning.
Yeah, and again, we'll take the report as read, its updates on the siblings and the ongoing uncertainty in terms of some of the delegation responsibilities around that. That also goes through how we've been working with special education finance colleagues and where that where we close the year end at 24-25 and how we've set that up for 25-26. So other than that, take the report as read, and in the appendix is the group committee annual.
Simon on it. Thank you. Next item is the Strategic Commissioning and Productivity Committee. Please don't ask any questions. The report is pretty straightforward. The committee has now had 2 meetings, so it's finding its way into terms of reference, but it's becoming a very good internal ICB committee to monitor key commission decisions, contracts, etc. It's working well, and we look forward to that committee developing its function. Thank you. Next item is the System Transformation and Digital Group Briefing Report. Andrew.
Thanks, Chair. This, again, much like the other reports, slightly out of date now. We've had 2 meetings since this one, including one this morning. So continuing to work at, or trying to work at pace and with impact on all of the key priority areas, particularly around shared services, around neighbourhood health, and around urgent and emergency care. So I have to take any questions on the April.
Okay. Thank you. And finally, Strategy and Rent Committee.
So, thank you, Chair. I'll take it as read, but just to highlight, it was our inaugural meeting. We recognise the need to align with health and wellbeing boards and the role that the local authority plays as part of the system group. And we also welcomed Andrew as the chair of the system transformation group to align the strategies with transformation. We supported the prevention framework. We wanted to ensure and make a point that all committees work towards prevention and have that at the heart of the strategies and the work that they're doing. We commended the finance strategy to move forward, but we did put a big piece in the prevention, and that to be recognised. And excitement, we're waiting for the NHS 10-year plan to review the strategies against this. Thank you, Chair. Take questions.
Look forward to the report. Plan coming out next week. Be good. Thank you. Any questions for Kath? Thank you very much. Okay, moving on then to risk reviews. I think you've covered all the risks that you face at the moment. Any other business?
Only one, Chair. Sorry, I know you're keen to, that was just to say thank you, because with Ian starting on the 1st of July, this will be your last meeting about there. And from funding in from when Sir Neil McKay stood down, just wanted to say thank you for your support and leadership and for covering that space.
That's it. And thank you all for all your support on the last day. Thank you. Meeting closed. Thank you.
Right.